All right, well, good morning, everyone. Good morning. Good morning, Dr. Ward. It's wonderful to see everyone here. I know it's a Saturday morning early, it's summer, it's humid, it's all of those things. Thank you for being here. A lot more hopefully will be trickling in, and there are many more online. It's difficult to get that feeling it's a larger meeting, but it is. Thank you for being here. The person who's supposed to introduce me, Dr. Singhal, is sleeping. We just discovered that right now. He's taking a shower, and he'll be here soon. I promised him I'll make that public news. So I'll introduce myself. My name is Hashem El-Serag. I'm a professor and chair of the Department of Medicine here at Baylor College of Medicine in Houston. I'm co-directing this meeting today. And this meeting has happened through a collaboration between Baylor College of Medicine, where I work, between TEC, which is the Texas Collaborative Center for Hepatocellular Carcinoma, a center funded by the Cancer Prevention Research Institute of Texas, Rice University Baker Institute for Public Policy, where we're sitting here today, and those four entities resulted in today. Apart from welcoming you, I'm going to give you an overview for why we're here today, set the context for the rest of the day, and get us started. So this is the TEC, and I encourage some of you, all of you, to look us up on the website. It's an entity that is funded now 3 years ago by Sept, and the reason to fund it, this is what they want us to do, that's what we proposed, is to reduce hepatocellular carcinoma mortality in Texas by reducing the number of people who develop the cancer or by detecting it early to treat it. So it's focused on prevention and early diagnosis, and they wanted us to make an impact. Our goal is not new discoveries only, but to reduce the mortality. We had several main arms of the mission. One of them is to support and enhance research collaboration among the different researchers. The second is set up the frame to educate healthcare providers and the community. And the third, which touches on today, is engage stakeholders and solicit strategies to improve HCC-related prevention in care and best disseminate those improvements, engage private and public entities in policy considerations. So the last 2-3 bullets is or pertain to today's purpose. To anchor this, some of you who live in Texas know this, others may know that. Texas right now leads the nation in the incidence of hepatocellular carcinoma or liver cancer, the primary form of liver cancer. So while this map shows that there are several red states in the south and the west coast, Texas is number one. I believe Louisiana and Mississippi compete for second and third place. So that got the attention of Sept. And this is the incidence rates of hepatocellular carcinoma in Texas. In this graph, there are 6 lines. The top 3 lines pertain to Texas. The very top line is Texas Latinos. Texas Latinos have 3 times the incidence of HCC as the national average. It's really staggering rates. Some parts, and you can look at the color-coded map of Texas there, the border counties, some of them have incidence rates akin to China, Taiwan, Korea. I mean, the really, really high rates. Why this is a big deal? Because it's a highly fatal cancer. Thank you, Dr. Rich, for sharing the slide. In anyone who gets liver cancer, on average, the mortality is very, very high. So 1 in 5 would survive in 5 years. In Texas, it's even worse. 1 in 6 would survive in 5 years. So we have the highest rate of a highly fatal cancer, and some groups in Texas have rates that are off the charts. Why we're here? Because also hepatocellular carcinoma happens to be quite preventable. We know the risk factors that cause most cases of hepatocellular carcinoma. It's hepatitis C, non-alcoholic fatty liver disease, alcoholic liver disease, hepatitis B. We actually know how to screen for these major risk factors. The discoveries and the tests have been done, and people know what the tests are. We know how to diagnose them, and we can treat them. And in many instances, the treatment are almost miraculous. So Hep C, we can now cure 90% of people with Hep C. We can achieve adequate suppression of the virus in 90% or more of those who have Hep B. Alcohol and NAFLD, there are lower rates of success, but there are algorithms of what to do. How do those risk factors contribute to liver cancer? You're going to hear a detailed talk by Dr. Thrift. But this is a representation. Hepatitis C, while declining because of the treatment and detection, still the major cause of hepatocellular carcinoma in the US and in Texas, followed by alcoholic liver disease, followed by non-alcoholic fatty liver disease and hepatitis B. So the map of risk factors looks like this. And there are national goals, and you're going to hear our keynote speaker at lunchtime, Dr. Ward, telling us a lot more about elimination plans and goals. So there are national goals to eliminate hepatitis C, and depending on the plan you read, it's either 2020, which passed, and 2030. So people have starting setting benchmarks that we in Texas, and I'm not spoiling anything here by saying we're way far behind. There's also a global pandemic of obesity. Unfortunately, our state also competes for the top 2 or 3 obese nations or states in the nation. That is highly linked to this entity of non-alcoholic fatty liver disease. And I want to highlight here that 1 in 3 Latinos in Texas have fatty liver disease. 1 in 4 adults in Texas have fatty liver disease. Of those with fatty liver disease, 1 in 5 would develop this entity called NASH, which has more scarring and fibrosis, and that leads to cirrhosis. You'll hear a lot about cirrhosis today because it is the major underlying condition that precedes liver cancer. And the problems, unlike or maybe more than hepatitis C and others, is non-alcoholic fatty liver disease, while common, is highly under-detected. So 20% or so might be even mentioned casually as a diagnosis, much less are counseled regarding their disease, much less are referred, and much, much less undergo real workup and treatment. So hepatocellular carcinoma is a major entity in Texas. We lead the nation. Latinos are mostly affected. It's highly fatal. We know what the risk factors, and we know how to treat them. Our consortium have broken down the steps and the pathway to prevent and early detect hepatocellular carcinoma, and we published this recently. And we kind of know what the steps are. It starts by risk assessment, primary prevention, detection, and there are well-delineated steps under each of these boxes. And then we dreamt up of possible interventions that would underlie this, but we discovered that writing these things on a piece of paper will be just that, on a piece of paper, and you get a nice glossy publication. And we're hoping today will be a start of moving that glossy piece of paper into real action by bringing different stakeholders to advise us, to form a coalition, and to take next steps. So going back to wrap up, today's meeting is integral to the consortium. It touches on those 2 main points, and we're trying to change policy, or policy changes may be in the works by the end of the day. If you look up how people change policy, there are different things involved. The first one is problem identification, and I think today we'll cover this squarely. We will define what the problem is. We'll give you a flavor of the green part, which is policy analysis. What is there and what is not there? And then we have all the other colors left, which is formulate a strategy, policy development, policy enactment, etc. In the center of this, which hopefully today is the start of it, is the stakeholder engagement and education. So today's meeting format will have a morning speakers. They'll define the disease burden. They'll define the known methods for screening, diagnosis, and the methods for that, determine the important gaps in current practices relevant to Texas as much as possible, describe successful demonstration projects that have already been done to remedy some of these gaps. At lunchtime, we're going to have keynote speakers addressing the global and local hepatitis C elimination efforts, and we'll have also a speaker about the payer's perspective. In the afternoon, we're going to have an hour and a half of a multi-stakeholders meeting discussing a roadmap towards prevention and early diagnosis, identify high-impact policy changes, and discuss next steps. I believe many people who showed up today is the beginning of the coalition. I'm not going to read every line here, but that tells you about the people in this room and online and others who lent their support already to this initiative. So I think the coalition is already forming, and I'm looking for it to solidify throughout the day and afterwards. So my summary, I said it several times, but I think it's important to reiterate. Texas has the highest rates in the nation of HCC. Prevention and early detection are paramount. There's already considerable knowledge about HCC prevention and early diagnosis. There are clear gaps that you're going to hear about in this prevention effort. Many of these gaps are addressable through better implementation of known strategies and tactics. Some gaps may require new solutions like policy changes, and today, hopefully, is a first and an important step in setting up a roadmap with products that may include a white paper, an executive summary, policy changes to pursue, and strategies possibly to pursue those policy changes. So thank you very much. It gives me pleasure to introduce our next speaker, Dr. Aaron Thrift. He is our senior liver epidemiologist here at Baylor. He's an associate professor in the Department of Medicine, and he'll describe liver cirrhosis and hepatocellular carcinoma 101, focusing on disease burden, risk factors, and disparities. Aaron, thank you.
Right, thank you, Hashem. We've tried to sort of reduce the overlap between my talk and his, but he certainly stole my thunder. The intent really of mine is to bang home the same messages. Liver cancer is increasingly common, with high mortality rate. It affects minorities in the US, particularly in Texas, but is highly preventable, and I'll show some data to support those statements. This is why I'm here today on a Saturday instead of being at home rewatching Bluey with my kids. If you haven't seen it, you really should. So this figure shows percentage change in mortality rates for various cancer types in the US. If it's red, it means it's increasing. If it's blue, it's decreasing. And as you can see, liver cancer, the majority of which are hepatocellular carcinoma, is one of the only cancer types in the US with increasing mortality rates. Here it's shown at 0.5% per year. If we looked at earlier periods, that rate will be much higher. Building on the plot that Dr. El-Serag showed, where Hispanics in Texas have the highest rates for liver cancer in the United States, you can see here that actually incidence rates for hepatocellular carcinoma in the US, in Texas, cluster in certain areas of the state, and particularly along the border region, which obviously have high populations of Latinos. The increasing incidence of liver cancer is driven by what they call a birth cohort effect. So depending on when you're born, you and people born at the same time as you are exposed to certain risk factors or have a certain risk factor profile that you carry throughout your life. And we know, and there's very convincing evidence, and this plot shows nicely that the increasing incidence in the US has been primarily driven by a birth cohort effect, where baby boomers in the US were exposed to high rates of hepatitis C virus infection. In the figure you can see, sure, no. Plotted here on the x-axis is year of death, and the y-axis is the death rate per 100,000. You can really see that most of the increase in the mortality rate for liver cancer is among that birth cohort of people born in the peak hepatitis C infection era, so the baby boomer population. But what we're seeing now is perhaps a stabilisation of the incidence rates. If we looked at more recent data for the US, we see that after a sustained period of growth at around 4 to 5% per year, incidence rates for liver cancer have stabilised and may be declining in the US. And if we look at the same phenomenon of this birth cohort effect, so the peak there, the reference group is that hepatitis C birth cohort, and we see relative to that group, birth cohorts before that had lower incidence rates, and it increased towards that for a peak. But if you look at the most recent birth cohorts, successive birth cohorts now have fairly stable incidence rates. It hasn't returned to that baseline rate of people born in the early 1920s and 30s. So something else is going to sustain the high burden, but we're certainly seeing a stabilisation in rates. Okay, so there are three sort of distinct phases of cancer control, and today I'm sure we'll hear from all three, but my focus is primarily on prevention. So can we identify risk factors in order to prevent someone from developing cancer in the first place? This was touched on earlier, but primarily the main risk factors or the main etiology of liver cancer in the US is alcohol, hepatitis B, hepatitis C, and then NAFLD or NASH, as Dr. El-Serag mentioned. And that sort of risk factor profile does differ globally, but that's the focus of our efforts in the US. I wanted to present now just sort of a fairly theoretical idea of, given that we know what causes liver cancer, what burden of liver cancer is attributed to those, and therefore theoretically could be removed from the population. So we did that through estimating the preventable fraction, which is the proportion by which the incidence rate of the outcome, so liver cancer, in the population would be reduced if the exposures were eliminated. And just a fairly simple example, just to look at the number of cases attributed to obesity. So if obesity didn't cause cancer, and 40% of the population if overweight and obesity didn't cause cancer, and 40% of the population were overweight or obese, you'd expect the distribution of cancer cases would mirror the distribution of overweight in the population. So if you had 100 cancer cases, you'd expect 60 of those in the healthy weight group and 40 of those in the overweight group. However, we know that theoretically that being overweight confers 1.5-fold higher risk of cancer compared to being healthy weight. So what you actually observe is 1.5 times more cancer cases in the overweight group than you would if they had the same risk as the overweight group. So instead, as the healthy weight group. So instead of observing 40 cases in the overweight group, we actually observed 60 cases. And what we want to do is estimate the proportion of preventable liver cancer cases, which is a number of excess. So in this example, it would be the 20 divided by the total number, which is 120. So theoretically, if we removed the overweight from the population, you could prevent almost 17% of cancer cases in that example. So we did this. We did this for Texas based on cancer counts in 2015. To do it, we first of all, we went to the literature to find out what factors are known to be causally related to liver cancer. We need risk estimates, we need prevalence data, and then we can estimate the population attributable fraction. So for liver cancer, looking at places like the International Agency for Research on Cancer and other bodies throughout the world, there is convincing or strong evidence that alcohol consumption, overweight, obesity, tobacco smoking, hepatitis B and hepatitis C infection cause liver cancer. So with that knowledge, we set out to estimate this population attributable fraction. I won't go through it, but essentially It's a product of the proportion of the population exposed times the excess risk in that population. So if we went back to that prior example, if you look on the left-hand side of the slide, so 0.6 times 0, 60% of the population of healthy weight, we know that they don't have excess risk, so it's times 0. 40% are overweight, we know that they have 0.5 higher excess risk for cancer, so we get the same outcome of 17%. So what does it look like for liver cancer in Texas? It's actually highly preventable. Based on these 5 risk factors alone, and here we're talking about eliminating the exposure entirely, but in reality what you're going to do is shift the distribution. For example, you're going to shift the distribution of BMI to the left so that we have less overweight and obese and more healthy weight. But if we did that, we can eliminate almost 2/3 of liver cancer in Texas. That proportion does differ between males and females. We can see it's almost 70% in males, but 50% in females. And the contribution of the various risk factors is different across males and females. And it also differs by race, ethnicity. We can actually have a bigger bang for our buck in terms of preventing cancers among the minority population. So in particular, non-Hispanic blacks who have 2-fold higher incidence of liver cancer compared to non-Hispanic whites. Over 80% of cancers in males could be prevented if we focused on those 5 risk factors. I didn't touch on NAFLD specifically, but we know it's a consequence of obesity and metabolic dysregulation, and Dr. El-Serag mentioned the prevalence here in Texas. It's a global problem. In North America, around 35% of the population have non-alcoholic fatty liver disease. And it confers higher risk for liver cancer. Here, just plotted is the cumulative incidence for liver cancer in controls versus, in NAFLD patients versus controls without NAFLD. So what we can see is that there's a clear separation between those two curves. NAFLD confers around 8-fold higher risk of liver cancer compared to the general population. However, the risk conferred by NAFLD is actually lower than what we see in hepatitis C, and it's actually lower than what we see in cured hepatitis C as well. This is a cirrhosis population looking at incidence of liver cancer over time, and we can see patients with non-alcoholic fatty liver disease related cirrhosis have the sort of lowest risk in terms of future risk for liver cancer. Bringing it back to the cohort effect, I mentioned earlier that it's stabilising. We're seeing successive generations with similar risk, but we don't know what's going to happen in the future, especially with that growing population of patients with non-alcoholic fatty liver disease, especially in the growing Latino population in the US. So we have to sit and wait. Or we could work on prevention. So key points in terms of my slides. Liver cancer is highly preventable. We focus on hepatitis C screening and treatment, NAFLD or NASH screening and potentially dietary intervention in those populations. There is a change in risk factor profile that Dr. El-Serag mentioned. So less active viral hepatitis, more obesity, metabolic syndrome, and NAFLD and NASH. There's a change in the risk conferred, as I mentioned, from these risk factors. So we're going from a risk factor, hepatitis C, which is fairly low prevalence with a high relative risk, to a NAFLD, which is very common in the population but confers a lower risk compared to hepatitis C. So what do we need? We need enhanced primary prevention efforts, a focus on risk stratification, and to address the high burden in minority populations in the United States. Thank you.
Thank you. Our moderator now will be Dr. Montalegre. She is the co-director of the Community Outreach Committee and the tech and our implementation guru at Baylor College of Medicine.
Good morning, everyone, and welcome. We're so excited to see everybody here coming together to figure out how we're going to deal with this growing liver cancer problem in our state. So I'm very excited about the session that I'm going to be moderating, which is on advances and gaps in risk and risk assessment and prevention. I would like to introduce our speakers. my colleague and friend, Dr. Sumit Azrani, who is a transplant hepatologist at Baylor University Medical Center at Baylor Scott and White Health. Dr. Azrani, please come up. We also have Dr. Brett Fortune, who is the medical director of liver transplant at Montefiore Health System. So if you please come up and take a seat, we'll have everybody come up here for the session. And then Dr. Barbara Turner, who is a clinical professor of medicine at Gurr Family Center for Health System Science and Innovation at the University of Southern California. So please, you may win the prize for having traveled the farthest. So please come up. We'll take a seat over here. And then Dr. Azrani, we'll start with you. Dr. Azrani is going to tell us about the current state of prevention of liver cancer at where we are and what are the gaps in prevention that we can address. So without further ado, Dr. Azrani, thanks.
Thank you, Jane. So I'll talk about, where are we in terms of preventing liver cancer and sort of, highlighting this whole issue of, how do we assess patients, how do we prevent cancer? This is the big message. Yellow is the new red, okay? For all those people who think cardiology is so cool, no, it's all hepatology, okay? So yellow, our patients get jaundiced, okay, so yellow. And red, cardiology. And the thought is that, we've, as a society, paid so much appropriate emphasis to cardiology and heart issues and women and heart disease, but we've sort of forgotten liver disease, which is sort of coming up. And there's so much overlap, and we'll comment on some of that. And I'll go into that. And the three big things, to sort of think about is, again, the same message. It's fatty liver, alcohol, hepatitis C. For liver cancer to develop, for most cases, you have to have cirrhosis, and that's where the liver is getting scarred and not working as well. So the process takes about 20, 30 years of having a hard liver, and then in a subset, you end up with liver cancer. Across the world, 2 million deaths because of liver disease. In the US, about 60 to 80,000 deaths a year. Every year, about 20,000 wait for a transplant, and about 8,000 get a transplant. Liver cancer is up there. And then again, Texas has one of the highest rates of cirrhosis and liver cancer in the country. And we looked at this just in Dallas-Fort Worth. So this is looking across healthcare systems, so not just Baylor Dallas, UT Southwestern, Methodist. And we line up all the 85 hospitals in the Dallas-Fort Worth area. And this is what you see. On the left side is this growth of liver disease across. And this is reflective also in national data. And on the right, what we said is, okay, we talk about heart failure, we talk about COPD, what about liver disease? So if you just look at liver disease as compared to other chronic conditions, and here, liver is the red, is what you're seeing is there's been this dramatic increase in liver-related burden over the last 10, 15 years. So other chronic conditions have done a good job in terms of controlling things, but liver is up there. And the other theme that we've seen is that many of our patients are transitioning into this Medicare population. So it used to be 40s, 50s, and now about 40, 45% of our patients are above the age of 65. So another thing to think about how things have changed. And the cirrhosis patient has a new face. For those here who've been to medical school in the crowd, this is what we were taught. Right? Patient comes in and has, is wasting away, has this huge belly full of fluid, and that's what cirrhosis was taught as. But more and more, cirrhosis is becoming like this. It's really hard to say who has cirrhosis, who has not. And this is one of my favorite movies, 5 Points, if anybody knows what movie it is. Wally, there you go. Okay. 5, 10, 15, good. So this is where liver disease is headed, that it's become fatty liver, and we just are not that good at diagnosing it. One of the big things is, don't lie, everybody in this room drinks alcohol in some form or the other. And if you look in the in the world, 2.4 billion people in the world use alcohol. 2.4 billion in some form or the other. So keep that number in mind. 2.4 billion use alcohol, 24 million have a scarred liver or cirrhosis, 2.4 million have decompensated cirrhosis with the complications set in, and then out of these, about 300,000 deaths. or 200, and this is just because of alcohol. So alcohol, in a way, for every 100 deaths, 1 out of 100 deaths across the world is related to alcohol. Second is fatty liver. And I'll walk you through this. So each of these bars is one single year. And this is looking at, let's say on the left is Europe, Asia, then getting into, in the highlighted box is us, is every single year, this is how fatty liver or obesity has increased. And we, in the high-income West countries, have the highest skyscraper in terms of fatty liver disease. So even obesity and alcohol, again, that's the second thing. And then the third thing is hepatitis C. So this was sort of earlier data. This was before some of the new treatments had been more mainstream for hepatitis C. And what you're seeing on the x-axis is the years, on the y-axis is the number of cases. And we're sort of, as Aaron also highlighted, is we're sort of at that peak of cirrhosis related to hepatitis C, but the burden of liver cancer continues related to hepatitis C. So despite the treatment, we need to be aware of the risk that continues. And so what's our current state in HCC prevention? When we think about the continuum of how patients progress through this, and you can put in any chronic disease here, right? You have chronic liver disease, then you have cirrhosis, where the liver gets scarred. Then you have decompensation, whether you run into trouble because of your liver. You can get liver cancer. And then your option sort of is either you linger on or it's transplant and death. And the big thing here is how do we, in this group here, look at those three things that I've highlighted. One is how do we get patients to be recognized early? How do we treat early? How do we predict progression so we catch patients at the chronic liver disease state and not let them go through this whole pathway? And it's repeat. I came up with this mnemonic, so please appreciate it. Okay, so there's recognize early, which is, this is what we do, right? We visits, labs, imaging. We educate, community, patient, provider. We try to predict, visits, labs, imaging, and then we treat, medicines, procedures, transplant. So that's what our paradigm is, right? If we really boil down to it, what do? We just repeat the cycle. And what does prevention look like for all these three different conditions that I talked about? Ideally, what would happen is we would, for hepatitis C, have universal testing at primary care. Right now, everybody above the age of 18 should be screened for Hep C. And then, so looking at, Jeff runs a network of, 7 clinics in Dallas. Does everybody get access to it? I don't know. Or Craig, who's also in the audience, who's heading HTPN for Dallas. Does everybody get to this? I don't know. So step 1 is universal access, testing at primary care. 2 is early access to therapy. 3 is you treat them. You vaccinate for other conditions such as hepatitis B. And then you surveillance the high-risk patients and increase liver cancer awareness. Simple paradigm. What does prevention look like in the ideal world for alcohol? Right? Alcohol, you again screen at the primary care level, use tools such as audit. We somehow link patients in, again in this ideal world, to mental health and other support. And then you provide access to specialty care, if needed, for chronic condition management, and have some kind of structure to surveillance for liver cancer. And what about in fatty liver? The issue here is that the prevalence of fatty liver is so high. So we may see 100 fatty liver patients. Not everybody will progress down that path of badness. You probably have a few high-risk patients, but how do we identify those high-risk patients and then escalate care for them? And that's something that Brett Fortune is going to talk about in a little bit. Because even for our fatty liver patients, just to again reiterate this message, is it's not mentioned as a possible diagnosis. So recently, just we looked at our data of how many patients in the Baylor healthcare system has fatty liver, and we came up with a number. But I thought about it. How often do we code for fatty liver? Oftentimes we say elevated liver enzymes or something else, abnormal imaging. So the burden is probably not reported as much. So 1 out of 5 patients who really has fatty liver really gets diagnosed with that. 15% get counseled, because we just don't have the tools. And how do we get change to happen, right? Third thing is for appropriate patients, maybe 1 out of 10 gets referred. And in terms of investigation, how often do people get liver biopsies to figure out, how sick they are? And so prevention in an ideal world for fatty liver does become more involved, right? You have, on one hand, you have the nutrition classes, the weight loss therapies, you have chronic disease management. How do we get patients involved for novel therapeutics, exercise regimen, linkage to care, community education? So again, a lot needs to be done for a population that is really going to explode. So where are the gaps in HCC prevention? I think there are 3 big categories. One is underdiagnosis of main risk factors. How often do we really screen for alcohol? We talk about it, maybe in specialty clinic, but do we do it regularly? 2 is education at different levels. And 3 is linkage and access to therapy. Issues. We don't systematically predict high risk. Okay, question number 2. Which ad is this commercial? Anybody know? Yeah, Mac versus PC. Okay. So we don't systematically predict risk. So if you have 2 patients with liver disease in your office, primary care, specialty care, doesn't matter. We really don't have good tools to figure out who's the one that's going to run into trouble. We have this paradigm for other cancers, right? For colonoscopy, we think of colon cancer, we think about colonoscopy. We have people filming their colonoscopies, right? Just recently, last week. For breast cancer, we think of mammograms. For diabetes, we think of A1C. What is the piece for liver disease or liver cancer? We really don't have anything. And we'll highlight some of the tools today, which may or may not be the answer, but at least it'll get us in the right direction. Because at the end of the day is how do we find out who are the people that we really need to worry about? 2, besides early sort of identification of the high-risk patient, is lack of awareness or education at the patient, physician, and public level. Here are a couple of the handouts that we've created. One is one with tech. And how does one sort of disseminate this kind of information, and is it even useful? On the right is some of the materials that we've created for our clinic in Dallas, in English and Spanish. We partnered with some other institutions to develop this. We've added videos. But how do we sort of, get it down to the population that really needs it, and not just educate the patient, the public, but also the physicians taking care of our patients? And 3, the linkage to care, which is lacking. PCP and specialist access, proximity to large centers. Here in Dallas, Fort Worth, you can get care. But what about in Waxahachie, Corsicana, Ennis? How do we get out there in our communities? 2 is, again, on that point, how do we get to our disadvantaged populations, our minorities, low income, rural? And Dr. Rich is going to talk a little bit about that. And how do we really leverage our integrated healthcare systems to make impactful change? And how do we come up with care pathways that we can use across Texas? And then finally, access to therapy and resources are spotty. This is, everybody's wish list. Everybody with their, disease of choice will ask for similar kinds of things. But that's what we need. We need sort of some concerted effort to really prevent this progression of disease. And I'll bring it down to economics, and this is the last slide. Okay, so I talked to you about the paradigm, going from chronic liver disease to transplant to death. If we really think in terms of numbers, right, if we can invest right now at the chronic liver disease on education, lifestyle modification, nutrition, 10,000. Again, this is my ballpark number. Once they get to the scarred liver stage, this is what it's costing our system, right? So we have patients who come in every 6 months, get their labs, imagings, medications. That's about 60,000 a year. Once they run into trouble, then they get into the cycle of hospitalizations. 3 to 4 hospitalizations per patient, cost about 30,000 per hospitalization. That's 120,000 right there. Then our patients get procedures and medications at that level. That's another 100,000. If we get them to transplant, yay, okay. That's, at our center, maybe 125 patients. That's about 200,000 plus the repeated hospitalizations after that. And then finally, again, besides the human cost, if we just think in terms of economics, our patients, if they're dying in their 40s, 50s, 60s, right? This is not cardiology where it's 70s, 80s. And this is sort of premature death and lost productivity. So again, even in terms of economics, it makes sense to start now. And I think this kind of approach to go across healthcare systems, across Texas, is really needed. So I'll stop there. Yellow is the new red. And thank you for listening. And then I'll introduce Brett Fortune just briefly. So Brett Fortune is a good friend. He's trained in Colorado. He's trained at Yale. He was at Columbia, and now is putting his stamp at Montefiore as the medical director of liver transplant. His passion is taking care of disadvantaged populations. But the second thing is his interest is how do we leverage all this EMR, electronic medical records that we have to make impactful change. Brett.
Great. Thank you so much. So just the forward button here. Good morning, everyone. Thank you so much for having me. Thank you for the organizers for inviting me to this amazing effort, and hope to take a lot of this information to take it back to New York, where we definitely have some vulnerable populations that are also dealing with substantially above average risk of advanced liver disease and cancer. So let me get to, oh, this is not my talk. Is it out of order? This is your second talk. Is there an AV person? Sorry, it's put back to back. Oh, here we go. Thank you. There we go. Oh, yeah, there's just a quick pause. So anyway, while they're putting it up, I'm very excited to kind of go over more of the conceptual framework that I think is really necessary to address. In medicine, we're one of the few fields that really has been slow to utilize technology, and I feel it is really where we have to go, especially when you're talking about the kind of population size, particularly in fatty liver disease, and the really lack of care support, because obviously a hepatologist can't see every one of these patients. Our clinics are inundated with a lot of these patients, and yet we cannot meet the means. So really trying to figure out population science and using technology to better empower primary care doctors as well as patients is really the next step. So anyway, as Dr. Zrani kindly mentioned, I'm the medical director of liver transplant at Montefiore, which is located in the Bronx, New York. And we're going to talk about kind of using technology to better create risk assessments as a tool for prevention, particularly in advanced liver disease and cancer. These are my disclosures and no conflicts. So what I hope to do, or hope the group in general at the end of today will be able to talk about what do we know now, which has already gotten a great start, and hopefully by the end of today, we'll even have more knowledge. And so some things that you may see commonly described in every of the talks is right now, healthcare systems poorly screen for chronic liver disease, period, even among those with greatest risk. And as Dr. Zrani showed on that illustrative slide of Pixar movies, it helps show that it's getting harder and harder to identify these patients because they appear like the general population. Obviously, I think it goes without saying that detection of earlier disease is better than late. It's not only better from a more therapeutic response, but also from a cost-saving standpoint. And in this case, we're talking about trying to prevent before they develop early fibrosis or scarring, and obviously development of decompensation, liver disease, or cancer. And then obviously trying to standardize this so that implementation of processes and policies can be applied anywhere or wherever, whether it's urban, large center, small center, and that would be the ideal setting. But the question is it obtainable? And if so, how do we do that? And maybe we'll be able to highlight some of that by the end of today. One of the things that I think, and I'm definitely investing in, is I believe technology can help us, as it has helped in many of our businesses and medicine over the years. And one of the benefits since healthcare has been kind of switched over to an electronic health record is the ability to use big data and machine learning and artificial intelligence to help the human aspect. And so how do we identify these patients? How do we properly risk stratify them? And then, as I mentioned, and it was kind of referenced earlier, is how do we interact with physicians? Because again, hepatologists cannot take this burden completely by themselves. It's impossible. Just like gastroenterologists can't do every colonoscopy on an age 45 or above person. And so we have to empower our primary care force. We have to empower our patients to take recognition and to really get involved in their care. And how do we link them to that care? As pointed out, there are many determinants of health that really reduce your linkage to care. And then also making sure that there's response feedback, because it's one thing if it's a one-way street, but if you're not hearing how things are going, you're really not going to make any improvements in the future. And then lastly, to move forward and turn this into reality, we really have to have partnerships such as what is happening today and implementation science so that we make sure, again, that we're doing the proper feedback loop to see if things are working or what are not. So as you saw earlier, Dr. Serrani's slide, why is disease screening important? As you can see here, all these things are here, but the point is, as he mentioned, that we do not have a proper screening tool for advanced liver disease or cancer. So the question is, can technology help us to create some screening tools, even to at least highlight those at greatest risk for developing chronic liver disease and thus liver cancer? And so looking at his paradigm natural history of liver disease, obviously we would like to identify those patients earlier in the process, not only for outcomes, but also cost. But as opposed to his repeat acronym, we do want to identify these patients early before they develop problems. We want to risk stratify them. We want to get that linkage to care. And then we want the feedback, because again, doing everything one way and not having any feedback does not tell you if it's working. And so it's really important to put that in when you're building these systems. So identification using technology, there can be developed algorithms of using both diagnostic codes, disease groupers, some specifics depending on your electronic health record platform that to help capture these patients with pretty high accuracy. And a lot of my colleagues throughout the country and world have really worked on validating these codes with beta testing and showing very high sensitivity specificity with high accuracy. And so we're learning with the big data of how to identify patients with early alcohol use disorder or early alcohol liver disease. More than just having abnormal liver tests, but also looking at patient-reported outcomes. Every one of these patients has a social history. We're improving our access with the portal, where we actually can use questionnaire surveys. How much are you drinking? Because sometimes patients feel more comfortable answering those questions at home as opposed in the waiting room or in front of the doctor. And so getting more honed in and targeting these patients sooner, using those discrete data can be more helpful of really identifying them quickly and having intervention. And the same can be said for fatty liver disease, not only looking at their metabolic profiles, which are commonly tested in almost every patient, as well as BMI, et cetera. So again, other ways to really capture these patients. And then viral hepatitis, both B and C, whether it's positive serology testing or the birth cohort, et cetera. So what do we do from there if we can identify them? Well, we can risk assess, and there's actually been a lot of literature really looking at non-invasive, simple laboratory-based tests to help with risk stratification to detect advanced fibrosis, which again is the main proponent that leads to decompensated liver disease and cancer. And so how can we simply use, sometimes simplest best, and how do we use this simple risk stratification to help take those patients that you have identified as having liver disease potentially, and then risk stratifying them into certain categories so that you can know different interventions may be applied. And so, for example, the FIB4, which is the 4 components of fibrosis, has been a commonly validated test for the last almost 20 years now of looking at just simply the patient's age, an AST and ALT, which are commonly obtained labs for liver function, and platelet count, which is actually the least commonly tested. But putting that into a score, you can simply be able to risk stratify patients based on validated cutoffs per their liver disease etiology. And you can actually without doing anything further, can actually accurately detect whether or not they have advanced liver disease or the development of advanced liver disease in the near future. And so by knowing that, when you capture the audience here and actually identify these patients with alcohol, fatty liver, and viral hepatitis, you can then use these risk scores, whether it's FIB4, looking at positive serologies, and the Audit C, which is literally a 3 questionnaire for alcohol use disorder detection, which can easily be done over a portal. And then you can really be able to create risk-specific, disease-specific care pathways and risk stratifying both low risk, high risk, and if you want a third category, intermediate risk. And so that's where you kind of initiate both empowerment, recognition, tell your primary care providers, your patients that, hey, we've identified you as potentially high risk for chronic liver disease. You need to follow up. And with that, how do we develop that care coordination? It was mentioned earlier, it takes a village to manage chronic liver disease. And that's important, and part of a chronic disease management model is to include the patients, their communities, and their primary sector, both PCPs, advanced practice providers. It really can't be where healthcare is kind of turned into this very specialty heavy delivery system. We have to flip it back to the primary care pre-prevention level. And so notifying them, hey, we've detected that you might be at risk for advanced liver disease. We can actually message them through the provider, through the portal, through their providers, and create actually validated decision pathways that can be very helpful, that don't require a hepatology consult. So with that, as I mentioned, notification of the provider, hey, we detected your patient might have liver disease. And we could do this through the entire health system and message the patient, hey, we just wanted to let you know we detected this. These are the things we would suggest. Obviously, technology still has its own implicit biases and some disparities, which will continue. But I could tell you, as every American almost has an iPhone or some type of smartphone, technology can reach everyone, including rural areas or other vulnerable populations. So creating both best practice advisories, other portal messages, more surveys, developing both low and high risk stratifications, such as specific clinical decision pathways that for those low-risk patients, continuing screening intervals that might be more frequent, or having further follow-up with patient-reported outcomes to get more information through the portal, reassess based on a set frequency so they're not forgotten or lost to follow-up. And then for those that are high risk, we would have more intensive, more further risk stratification by using non-invasive imaging. So getting your ultrasounds, which we're trying to avoid on every single patient because you could obviously state that's probably not an adequate use of resources, as well as moving forward to some other technologies such as elastography to help further risk stratify those patients that are identified as high risk. And then for those with the highest risk, that's where you would then refer to your specialists or hepatologists and go forward with further therapies in the future, including both, but counseling for alcohol cessation is really general. Metabolic health and obesity management is general. That is not a hepatology practice. That is an everybody practice. And so we really have to get that empowerment and help educate the community, the patients, and all the healthcare system. So these are just some examples that I took. I work on a steering committee with one of the electronic medical record platforms, Epic, which is one of the larger ones. And there are ways to create risk identification based on certain parameters, such as for early detection of sepsis in admitted patients, which we know earlier detection and early initiation of antibiotics can actually save lives in just a matter of minutes, not even days. In addition, reminders of standard care practices. But what's really cool and something that's been underutilized that I think us as a community can further advance is there are actually these clinical decision pathways that are built in. They're embedded technology tools to help tell patients and doctors what to do if we detect that they have advanced liver disease. And using whether it's FIB4 or whatever risk stratification you want to use, this is embedded in the electronic medical records. These are recommendations of what we would do next. It's kind of your own virtual consult so that you can help get these patients care without having to be the only 10% that actually make it to the specialists. So you lose that 90%. So you can tackle them on the front line. In addition, you can prompt order sets that can go ahead and risk stratify and all those further things. So you can do all this workup before they even make it to the specialists. So these are things that need to be discussed and built in each institution, but it can be done, and it can be very successful. Finally, it's really important when you talk about implementation science about response feedback. You cannot just do something and never follow up to see if it worked or not. So creating kind of dashboards to track how you're doing. How are you doing with adherence? How are you doing with outcomes? Those kind of things are really important to build when you do these endeavors. And it's luckily these platforms all have the analytical capabilities of doing so internally. And so working with your IT groups or other platforms dependent, you can really develop a lot of these great dashboards and follow kind of the act, plan, study, do cycle, and really optimizing with ongoing feedback and improved performance. And a perfect example is the cirrhosis and cancer screening dashboard of the VA, which has made a lot of progress and really have almost helped create basically a report card of how each VA is doing in the management of their advanced liver disease and cancer. So, can we make it a reality? We need partnership, which I really applaud this consortium, this collaboration, and I really want to try to figure out how to replicate this in the state of New York. We need to take all the stakeholders and create an overarching objective or goal and form work groups that we can tackle this in a synchronized, coordinated fashion. We need to develop a standardized approach. You can't, if everyone's doing something different, it's hard to implement it. So you need to develop a consensus pathway of how to do that, both in the detection of advanced liver disease as well as screening. You want to make it cost effective, high yield. You can't make it super expensive. You can't make it super unavailable. You know, we can't use MRI-based technology. We need lab-based technology. And we need ongoing assessment of how we're doing. We need to develop, as part of the plan, yearly or every other year, reassessment. How are we doing? How are the dashboards looking? How are we making a difference, as opposed to waiting to your public health statistics to tell you? And so really, you got to involve your policy people, which we're excited to have you here today. Your platform personnel. I can tell you, for example, Epic is extremely interested in really working with the hepatologists, gastroenterologists, and other specialties to enhance the utilization and optimization, because I know a lot of doctors really hate the platforms, but you can make it smarter and be more effective. Topic experts, patients, and providers, I think, is a key to get their feedback. What are their barriers to getting the proper help and education? We need to get a response from them, and obviously the healthcare systems themselves. So there is a future, and obviously what's really exciting is there are a lot of third parties and other companies that are looking at machine learning. You know, obviously the human can only do so much, but if you can take that big data and create validated algorithms, there could be really some exciting enhanced algorithms that are even more accurate than, for example, FIB4. Artificial intelligence is obviously taking what we learn and to test it further. Now, keep in mind, these have limitations and again, need to be reevaluated to make sure that they're accurate and not missing the big picture. The other thing is taking patient data. We can actually merge all patient-specific data into their own record and then merge that. So, for example, we can follow their weights. We can follow their sleep patterns. We can follow, you know, obviously this gets a little big brother, so you have to have a line. But the point is that you can take all this discrete data and really convert it into some very accurate algorithms. And then obviously, as I mentioned, I think it's really important to account patient-reported outcomes. We know that in chronic liver disease, patient-reported outcomes are independent predictors of survival, and it's very important henceforth with our prospective science to include patient-reported outcomes as part of that pathway. And so I call it health intelligence. The smarter we get, the better we will do in healthcare. And so it's really how we have to, as a group, really take this on as opposed to being resistant to it. So obviously there are a lot of strengths and weaknesses with electronic health record. The majority of health systems are now on the platform because of basically moving laws and stuff. And now there's over nearly 350 million patients. Almost every American has some kind of electronic health record. So there's endless opportunities to really utilize this data and really enhance our care delivery for these patients, regardless of where they live, regardless of what language they speak, regardless of what access they have. And so there are analytical capabilities. I mentioned some of the platforms here that can create dashboards, analytical reports, registries, et cetera. And there's a lot of opportunity to not only do this from the science side, but also the quality improvement side. And so to summarize, I believe technology can help us. I believe that we know that chronic liver disease and liver cancer are highly prevalent in Texas and really around the country. And there's a major need to improve this screen effort. I believe that if we really own technology and work with our partners, as opposed to just following what they provide us, we really can develop very highly intelligent algorithms to identify patients and really be able to perfect our ability for early detection and to be able to empower patients and primary care providers with the ability to care for themselves before they make it to the specialists. With that, accurate risk assessments so that each care pathway is risk-based with high yield and low cost, and then effective notification, as we mentioned, and then transparent, easily tractable care pathways in order to really enhance your linkage of care and proper implementation with response feedback. And with that, I really think we can help start to close the gaps in liver disease. Thank you.
As someone in public health and population health, I just could not stop smiling at everything that you just said. I really love how hepatologists in this room are really kind of thinking about primary care and communities. And with that, we'll have Dr. Turner, who is going to talk specifically about primary care settings and community health settings, where this is really, like Dr. Fortune was just saying, really this needs to happen. We can no longer have specialists be the ones who are responsible for the care for liver disease. So thank you so much for your coming. So Dr. Turner comes from Southern California, where she's a clinical professor of medicine for the Gare Family Center for Health System Sciences. And as I said, talking about community and primary care settings. Thank you.
Well, I think you've done a brilliant job of teeing up these lectures, because I feel that we really are very complementary in our vantage points. Mine is from primary care. I'm a practicing internist, health systems scientist. And I was here for 8 years. How do I make sure of this? Yeah. But I got to say that in Texas for 8 years, it's nice to be back. I don't really have important disclosures. I got to say I worked with Dr. Singal over there on my research while I was at UT Health San Antonio. So I'm really going to talk to you about implementing this, and it's not going to be an easy story. The vantage point I have is from a project that was funded over 6 or 7 years to implement HCV screening. It was a time we were focusing on baby boomers, focusing on treating them, and our concentration was in primary care practices throughout South Texas. You can see here in the orange, that's the location of the practices, and Bexar County and Dallas are in blue where we coordinated this. But they were 5 federally qualified health centers. I got to tell you, it's the real world, and it's not the epic world, unfortunately. But we gained a lot of insights from how we serve Medicaid and uninsured patients. It was launched actually in 2014 to 16 in these practices, and honestly, at baseline, no HCV screening was going on, zippo. And this was funded, fortunately, by CPRIT. We were one of the first groups to really get CPRIT, along with Dr. El-Serag, to realize how threatening liver cancer was. So this is actually data from the University of Washington. I just found it's like over 200,000 people in Texas still have chronic hepatitis C. We've got a big problem here. We've already heard about liver cancer, but I want you to focus on the red concentration down in South Texas. That's where we were working, way higher than anywhere else in the country, to be honest. But of course, we've heard the good news. We do have good news if we can only figure this out. You already know about South Texas, the world doesn't, but I gave this talk for federal agencies, and so I wanted to remind them it's mostly Latinx and very low income compared to even the rest of Texas. And so the challenge is, and we've heard about this, is the chronic HCV is a disease of low-income Americans, folks, and so that's another big barrier. I am an implementation scientist. I like using frameworks, so we use the RE-AIM framework to evaluate our study. Are we reaching the population? Is it effective? Are the people who are supposed to be implementing the project really doing it, adopting it, and is it being adopted or implemented with fidelity? And then maintenance is something we really couldn't address very well, but we're going to talk about today. This isn't repeat, but it's the same idea where we're focusing on screening. Now, we've talked a lot about the IT system, and I'll just mention the EMRs in these federally qualified health centers are bottom feeders. Many of them you cannot even modify. You can't use them to monitor patients. You can't use them to identify patients. And we had to lean on the staff to find patients who were eligible. Now, because they just didn't get support for that. And we tried to work with the systems and they couldn't modify them. So we have other solutions I'll tell you about later to help people know about screening, to minimize the burden of screening with reflex testing. And we made it through funding free for the uninsured. If you tell uninsured people they have to spend $10 on screening for hepatitis C, they'll say, no, thank you. So it's really important that we solve those problems. And then we did make a registry. Actually, we used the LabCorp and Quest data to find out who got tested because that was our workaround. I'll tell you about a mobile app we made. We did a lot of education. We already talked about that. I'll mention it. Protocols, I agree with you, are super important. And again, testing was free for the uninsured, including ultrasounds. We had to get deals with various radiology groups to make it affordable. I think we have a neat model in the office hours I'll tell you a little bit about. I know Echo is out there everywhere, but this is like low-tech Echo. It's a holistic care plan that involves these very complicated patients. So you really have to not just look at the liver. And then care navigation I'll mention. And finally, I just want to say a little bit, and I don't know if I have a pointer here, but prescription assistance programs from the drug companies. I know they like to make money, but they are at least willing to give the medication for free to people who don't have resources. And we took advantage of that with a cure. And the liver ultrasound is off our radar. I think it's a big problem, and I just want to mention that because I won't be addressing it. So we heard you need to listen to the community. That is so true. You have to go out and talk to people. So we had focus groups, meetings with clinicians, with patients to try to figure out how do we solve this and how do we help them. And we developed a website which has a lot of resources on it, or at least had it. It's called stophepatitisc.com, and it had resources for all levels, including clinicians, the community, and hopefully aiming for stakeholders, for people who are going to be funding so they understand what we need to do. Bilingual, low literacy. Challenge to sustainability, funding to keep it up. Community outreach materials. We developed bilingual, attractive materials to hand out at rodeos, at community fairs, and in our clinics. So people really understood more about the disease. We actually have them on alcohol. I got to tell you, I think that's a big focus. Challenge to sustainability, funding for active community outreach. We made testimonials. We got people who were cured of hepatitis C to talk about their stories, because it's not straightforward. And there were a lot of barriers that they had to overcome. And wanted other people to see it was possible to actually cure this disease. We made posters. Now, this is because of this challenge. Patients had no clue, they still have no clue, that they need to be screened for hepatitis C. And the PCP and the team had zero time to explain it. So you don't consent somebody. You say, here, posters, hepatitis C, need to be tested. And And nobody turned us down. Everybody said, oh, okay. So it's important to have the information out there so the team doesn't have to bother with that. Education for professionals. We went to all of these practices and gave them individual training programs. We gave them CME for it. We gave them lunch. We tried to make it incentivized. Alcohol, I've got to say at the bottom here, is a lecture that I give in New York too, because it is so linked for this population, and it is so important that we not ignore it. So we have a 3-part series on alcohol and HCV, but it's also just about alcohol screening and management 101. Challenge to sustainability, funding to continue it. This is cool. The mobile app we made is a very cheap little tablet because we did focus groups with patients, and we found that they had no idea once they were found to have chronic hepatitis C what it was, what should they do about it. So we had an app that we created that had teach back. So we gave them some slides and we said, did you get this? And then the care navigator or the team could just build on that. They didn't have to go through a whole la-di-da about the disease or what needed to be done. It really is that you have to address the stigma. This is not a disease that doesn't carry a problem with it. When you say you have hepatitis C, they say, oh my God, injection drug use, et cetera, and many people need to understand that it's not linked to bad behaviors or even suspect behaviors. The care manager was super important. I have to say, as a primary care physician who's practicing now in an environment where I really don't have care managers, it's really tough because it's all a lot on me. And here you can see at these practices, we were able to fund, depending on the amount of money, various people to help navigate and help these patients through the whole gauntlet of the care continuum. And I'm not going to go through all of this, but you get an idea just scanning how many things needed to be addressed. And this didn't require an MD to do this. Challenge to sustainability, payment for these people. And integration into the practice. When it was somebody that we hired and put in the practice, it was hard to get them to be part of the flow and to have people in the practice really consider them appropriately to utilize their skills. This is kind of cool. So our clinicians, when we went out and talked to them, said, I don't have time to do an echo hour, whatever, every other week. And so we said, okay, we'll get a hepatologist, a wonderful guy at UT Health in San Antonio, to have lunch every other week, and we'll set up office hours with him. And so we had a very protocolized, I'm not going to show you, form with the FIB4 and other data to review with the hepatologist. Only took 10 to 15 minutes, and there was some teaching going on at the same time on top of our lectures. And so we came up with what's the drug to use? What are the problems with this patient? What else to manage? All in that period of time. The care manager was listening and could help operationalize it. There are lots of challenges to sustainability here. How do you pay for a specialist time? How do you incentivize the PCPs to do that at lunchtime? Or even then take on the next steps of management. Payment for the tests of the uninsured, I've already mentioned. Here in Texas, it's a bigger problem than where I come from in California, but it's still an issue. And then the really saddest part was when people had liver cancer, because we had a lot of trouble figuring out for the uninsured how to manage that disease. And sometimes it was like, we can't do much for you. So effectiveness, was this useful? Did we get anything done? These are a lot of the measures that we used in this project, having to do with each one of the re-aim goals that we proceeded with. And I have to tell you that the outcomes that we measure in terms of treatment have to do with the uninsured, because that's the group that we could really control. So overall, this project screened 27,000 individuals in South Texas. We screened about half of them. Remember, we started from zero. And the demographics are really quite typical of South Texas. There were 2/3 were uninsured. And we found that 5% were testing positive for HCV, anti-HCV. And then we were able to get about 3/4 of them tested for RNA, which is another one of the problems when the reflex testing wasn't available. And then we found that about 350 had chronic HCV. Now, I have these two columns, just taking examples of the best performing clinic and the worst performing clinic. And although the worst performing clinic actually found more patients, you can see at the top, they only tested 20% of their population. They obviously were picking out the people that were high risk and tested them, which is fine if you think you're getting everybody you need to get. The best performance clinic tested about 70% of the patients, and they found a lower prevalence, but that's because they were doing everybody. And we were able to really manage, I think, a lot of the patients that should have been in most of the practices when we had all the pieces of the puzzle. And we can talk later about what pieces were missing in the worst performing clinic. By the way, this was all published in an Annals of Internal Medicine paper that we had with a qualitative assessment of what went right and what went wrong. But places that don't have somebody who cares a lot, a champion, we really couldn't engage them. If they didn't have as much staff support, an LVN is awesome for this because they can manage clinical issues as well as care navigation, but they cost money. PCPs care about something else, and we can talk about this later. HCV is one of many priorities, and we have to figure out how to put it on their to-do list because there isn't an incentive for this right now. And then the low-quality EMR is really a problem. The care cascade, I think, was already mentioned, but that this is an issue, and you can see right here how it plays out. Where you can't get everybody, all of those lab tests, the ultrasound done, couldn't get everybody to get that done. These are all uninsured, by the way, I have it highlighted. Getting that teleconsultation scheduled was kind of a pain, but we managed for about 145, and then we dropped down. There was a problem between the consultation and treatment recommended because people had major health issues that needed to be addressed first. So that would delay us going out and trying to initiate treatment. Once we did get the drugs from the PCPAP program, we pretty much were able to keep them in care. But this is a care cascade that's repeated all over the country as a challenge. So I have in highlight here things that really are big challenges to sustainability. Can't figure out how to fix that EMR in very low supported federally qualified health centers, can't pay for reflex testing, we can't even get the testing for the uninsured. We did make a registry, but we had to have special deals with the lab companies to figure that out. How do you fund care navigation, PCP training? How do you fund these teleconference office hours? I really think ECHO's terrific, but you have to be super dedicated as a PCP to do that. And then how do you address all the other things that are going on? These people, we published a paper, Ahmed and I, that in the Latino population, alcohol is a big player. And you can treat the HCV, but you still got that problem going on. And obesity. So it is kind of silly to treat just hepatitis C and think, oh, I've cured this patient. And then this liver ultrasound wasn't even on our radar. Policy changes, this is my last slide. I think we have to continue to go out into the community to get them to understand this threat. I think they all get breast cancer and to some extent colon cancer, but we haven't really engaged them enough on liver cancer. We haven't covered care, especially here in this state, for a lot of people. And we need to get that EMR to work, and we have to help those practices get the EMR that works. It's so difficult to be in a place that doesn't have Epic, I've got to tell you, because I'm practicing in a place that doesn't have Epic. And National Quality of Care Metric. This I'm so annoyed about, that NQF, the National Quality Fund, has not got this on their radar to pay primary care practices for doing screening, let alone care. So why would I bother when I get paid for A1Cs and mammograms and colon cancer screening? And then I think we have to, this is sort of out there, but an idea of episode of care payment. They do that for hip replacements, et cetera, but I think we have to think about value-based care where we get, once you find, if you screen and find somebody with chronic HCV, bing, your compensation goes up, it covers the care management, it covers all of those visits, and I get an incentive to want to do this. But right now, it lacks. So I just want to really say thanks to Sept. In LA, I miss Sept, and other funders have really been very important to this project. And we had a fabulous team. One of them is here, but lots of people made this work, and I want to say thank you.
Please, how are we doing questions? Do we have microphones? Okay, please come up if you have questions. I really appreciated, Dr. Turner, your last presentation following Dr. Fortune's, because I think what you bring up is that unless we design these things for equity and with equity in mind, we're going to essentially, make the gap even more profound. And I just wondered if you, doing the thinking that you're doing and then having sort of the real world experience of what this actually looks like in FQHCs and in many of the care settings that see the patients, how do we make sure that everything we do keeps equity sort of at the forefront? Oh, sorry, that's a big question. Any thoughts?
So you want me to figure out how to solve lack of insurance and lack of health care?
Yeah, please.
Okay. All right.
EMRs and all that other stuff.
Yes, I think Dr. Turner pointed out nicely that there are clearly some disparities that are necessary to address, which obviously applies to linkage to care and quality of care. And I think that is the whole purpose of this effort, is to help work on emphasizing with policy and coverage to be able to help those that are vulnerable to these gaps so that we can address. So I'll just leave it broad. Yeah, thank you.
Well, I think our audience we want them to participate. So any questions now from the audience?
Hi. So I have a comment and a question for Dr. Turner. So, I stood up there and gave my 10,000-foot view on, liver cancer is high as a high burden in the minority population. We can prevent it. It's very easy. Look at the burden we can prevent. And I think you brought us all back down to earth with sort of the realities of addressing liver cancer in that population. Just in the setting where you were funded, what does that look like now that you have moved and perhaps the funding has ceased? Just wonder what it's like in that setting now.
I don't know if this is on. It didn't end when I left. It kept going with Sept funding. To be honest, it may be sunsetting soon. That makes me really unhappy because Sept is like a godmother sprinkling fairy dust around where the real world will not allow us to do this. And I feel that the feds have failed, or at least I know that gastroenterology groups and hepatologists have gone to NQF to make this at least some kind of incentivized thing. But down in South Texas, they have a horrific problem with diabetes. And the guy said, can you help us because we have people coming in already with renal failure from diabetes. And so it's just an issue of priorities. And when you said it's easily addressed, I have to say obesity, really? Is it easily addressed? Because in my world, it isn't. And I think that we have really a wave of challenges coming on us. And you point out the issues, and then the last thing I gotta say is I'm a dinosaur. I'm a primary care internist. Do you know how many medical students are going into this as opposed to hospital medicine? So you think of this as being a resource in this nation, but it is a diminishing resource. And I think unless we deal with that pipeline, we also have a big problem.
So we've heard so many great talks, and you're going to hear summaries throughout the day, because the hope is sort of to move despite what looks like it's clutter and it's unsolvable. I think we heard beyond the shadow of doubt that liver cancer is really important here. The numbers, we can argue how much. We heard from several speakers. They kept reiterating that we know the risk factors. Then you see different progression in the efforts to prevent according to the risk factor. So Dr. Turner's actually is quite advanced. Like, many states don't have demonstration projects that shows that this thing works. Well, we have one and actually several others that have reached to a point where, hey, you could do it. And I love in your slides what is needed for sustainability. So we're fairly advanced there for a hepatitis elimination plan that is at the level of the state, that one can give them sort of almost the recipe for what it takes to sustain demonstration projects. But you've heard also about non-alcoholic fatty liver disease, and a beautiful futuristic talk about what we can do and what we can't do, but haven't proven effectiveness and efficacy and all of those things. So this is maybe early, and it seems like the deficit there is most people don't know anything about it. I mean, I remember when I gave my early talk, and I said 1 in 3 and 1 in 4, and I see a couple of heads, and I'm like, really? Well, most people don't know that. So I believe we have someone here in the Department of Health here in Texas. Is this right? Can I call them out? Yes, here she. Yes? Okay, the Houston Health Department. I mean, someone from, and I know I talked to several of you, and maybe you can share with us your perspective. What are the issues that face you in hepatitis elimination, for example, to sustain the efforts at the level of the state?
Sure. I'm Stephen Pont from the Department of State Health Services. So thank you for the invitation to be here. And I've been with the health department about 5 years. Prior to that, I'm an academic pediatrician, primarily focusing on childhood obesity and community health. So the primary prevention aspect of this topic is of particular interest there as well. So I think that everyone, I think, in America and the world is coming off the COVID hangover, and certainly us at the State Health Department and our colleagues in Houston and in public health all over have been dramatically affected from the COVID aspect that just further highlighted the disparities that existed before that certainly have lots of overlap with the factors that are at least partially causing the high rates of hepatitis C and hepatocellular carcinoma. So from our standpoint, yeah, I think we're very interested in that. We're a helpful partner in wherever we can. I think we're public and population health, so more on the prevention side, and certainly thinking about how we can help people make it be easier to make that healthy choice to have more of the prevention aspect. And I was curious from the presentations if anyone can unpack a bit more on, particularly in the South Texas and in the higher prevalence in Latino populations, what the thoughts of drivers are of that. Is it income? Is it health behaviors? Is it a genetic predisposition?
Sumit or Barbara, would you like?
No, I think it's a combination of everything that you just highlighted, and the question is, how much can we impact all those different aspects? So even like now, it's we're seeing families of patients with fatty liver, families of patients with cirrhosis, family of patients of with liver cancer also. And so yes, there is the genetic component. There's a lot of studies going on in that. But beyond that, on top of that, you add sort of the income disparity, access issue. I think that just compounds it even more.
And if I could, just add, we're also recognizing that this disease process is starting earlier in age. Yeah. We now have childhood obesity, childhood fatty liver disease. So it's also impacting the children too. So we're talking about decades of disease exposure.
Our anecdote is related to one recruitment site in McAllen, Texas, where we recruit patients with cirrhosis for our consortium. And we're struck that the vast majority, by vast majority, I mean 80% plus, don't have hepatitis C or hepatitis B, And you could track it to alcohol or non-alcoholic fatty liver disease in that area. And honestly, if you go to McAllen, you would figure it out very fast as soon as you land in the airport or go to the hotel. I mean, the phenotype of both alcoholic and non-alcoholic fatty liver disease is so prevalent. It's stunning, actually.
That's right. And I just want to build on that, we, at the end of our project, started to transition into wanting to evaluate people with abnormal liver function tests, let alone, hepatitis C. And the docs really pushed back. He said, but everybody has abnormal liver function tests. We can't manage this. And it's the steps and the thought process of how to do that efficiently was nowhere near being operationalized. So I think that's another really big opportunity, although again, I am dispirited when I have obese patients sometimes because it's such a tough road to hoe, unfortunately.
So we have a question here, then Dr. Conwell, then the Houston department. So the mic is, please.
Great, thank you so much. Good morning, everyone. My name is Adrienne Simmons. I am the Director of Programs at the National Viral Hepatitis Roundtable. We're a patient advocacy organization. I'm a pharmacist by training, but my vantage point is really viral hepatitis. And so I have both a comment and a question. My comment is that, we heard Dr. Azrani in your talk that cirrhosis has a new face. Hepatitis C certainly has a new face also, right? So when we're thinking about the populations that are disproportionately impacted, I was struck that people who use drugs has not come up in harm reduction being a strategy for prevention, which is really, really critical, right? We can't treat our way out of the hepatitis C epidemic. We've also got to have adequate prevention strategies like harm reduction. So that's something that struck me. My question, though, is around, we've heard a lot about EMRs, and I'm curious, Dr. Fortune, Dr. Turner, if you have any comments around, we hear feedback from providers around alert fatigue. And so in the context of a universal screening recommendation for hepatitis C, there are certainly ways in which we could leverage the EMR, but providers are inundated with alerts. And so I'm just curious if you have any experience about how to optimize that.
No, you're absolutely correct. I mean, there are many demonstrations of the alerts leading to immediate basically lack of utilization after like 2 months of implementation. So, and that's the point of ongoing feedback with your providers. I think 2 parts. Number one is not make it just an alert function, but more of a pathway to care for them function. So we're actually helping the providers with the ability to, what do we do? Basically a virtual hepatologist is helping them in the EMR directly to say how to manage the patient. So to me, that is helpful as opposed to just telling them, hey, this person might have fatty liver disease. Number 2, I do believe notification of the patient about their potential possibility of having advanced liver disease is important. And that, I think, is an appropriate alert in order to engage with their doctor so that we can close the loop and have a better rate of linkage of care. Because a lot of times, even when the doctor does recognize advanced liver disease with the patient, there's still the lack of connection of patient following up. And you saw that kind of upside down pyramid. It actually is even worse when you think about patients with more vulnerable discriminates of health. So I think it's twofold, and that's the point of kind of having ongoing provider input in the design of EMRs, which I think was the problem in the very beginning. And so we do need to make them more provider friendly and patient friendly.
Yeah, and I want to tag team. I wish this were a team sport, because I wish all of the alerts didn't come to me. I would like to have a care manager, if it has to do with chronic liver disease, that it goes to somebody else, so I'm not the only person to deal with all of it. I'm telling you, the EMR and the portals are killing us. And one of the things that worries me about going straight to the patient saying, you have chronic liver disease or may have chronic liver disease, is they go, and then I have to deal with the fallout. So I think it has to actually be very well in partnership. I agree. You want to answer?
Yeah, no, that gets, again, that's my point, is having this kind of, layered out phases and strategy. You're absolutely right. The portal fatigue on providers and how they're spending 3 hours outside their work for every hour of clinic is very relevant and very important. And so that's my point, is making it more sophisticated and more patient-friendly.
And a team. So again, and I think if we could offer a little education when we send a note out like that, maybe, chronic liver disease has to do with something that's really treatable, or some, nice things that go along with it. But as I say, a lot of the patients, and I'm out in LA and we serve at LA County, a lot of uninsured, they are not on a portal. They're still, that's why Epic is wonderful as a dream, and the VA is wonderful as a dream, but I'd love to get policymakers involved in thinking about how to really bring in all of these other settings that serve really the low-income vulnerable populations.
Yeah, I mean, there's other patient communication devices, even through texting can be done through a HIPAA-compliant app.
That's right.
So there are other modalities that don't have to necessarily, they can be connected to EMR.
That's a great idea.
But they don't have to necessarily be EMR-based.
As far as the other high-risk groups for hepatitis C, we're going to hear a healthy dose of that about the PWIDs and the prison populations during the lunch hour. So there's a progression in this talk. Dr. Connell.
A great session so far, very insightful. Dr. Turner, I think your presentation, I would echo what Dr. Thrift said, really bringing us down to the practical realities and many, many barriers that there are for eliminating hepatitis C. It's focusing on that. So if we want to think the next step, think a little big, and if we are thinking towards having a state level policy change, having a state level elimination program, the lesson that you learned, how do you think they will inform that plan at the state level? What are the few things that you would want to have the policymakers know as they think about the Texas level plan, having that plan and also implementation of that plan, which I can imagine how challenging it would be. It's not going to be one size fit all.
To be honest, I don't know a whole lot about the state plan right now. I'm sure that Dr. El-Serag does.
None,
but I have to say that I would like you to target the state plan. What it bothers me a little bit, and feds do this too, is they focus on Kaiser and big systems that are, it's like the rich get richer. And I feel very strongly about FQHCs being partners. I've tried to get them sort of involved in all of this, but again, they have so many other priorities that if you can figure out how. The other thing is to not make a liver-specific support, because we talked about obesity. If you could get the team that you're supporting for value-based care for liver disease to also help me deal with obesity, that would be a win-win, or diabetes. I mean, in other words, don't think about silos, but think about how it overlaps with all these other conditions. And I didn't mention substance use treatment, even though I'm really passionate about it. That was one of the things that prevented the care cascade from going ahead. I know you're supposed to treat everybody no matter what, but substance use was a problem for us in South Texas, and we didn't want to start people on treatment they wouldn't adhere to. And I know there's good data that they will, but it is still a problem in South Texas getting access to that. Sorry.
I would echo that kind of request for the afternoon, because that's what we'll be asking over and over again. If we had to go to policy changes, what would be the one or two big ticket items that would focus on? And obviously we don't know, and that's why we're talking today, but it's a legitimate question. Dr. Thrift?
Sorry, second question, I'm really taken by the panel. So the medical records you're flagging high-risk patients, do the patients, providers, or the system itself know what to do with that patient? What does someone do if you've been flagged as high risk for fatty liver disease? Then what is the
Right. So like I was saying on my talk, is you develop a consensus care pathway, which can be integrated as, for example, metabolic health pathway. You're absolutely right that, fatty liver disease is only one organ of the whole spectrum of other diseases, including cardiovascular disease. The red's still around. But no, that's the point. Is I think with ongoing group discussions involving patients, primary care providers, specialists, other stakeholders, I think it's very important to create consensus care pathways that everyone adheres to, and then we can actually embed that within the EMR. So when it's alerted, it's not just I'm alerting you, I'm actually going to do something about it.
So we're actually currently...
Yeah, you have a good example.
Yeah, well, we're at this implementation phase throughout our system in Dallas, is we realize it's not one size fits all. And so we're trying to target 3 different kinds of clinics. One is sort of the ones that serve underserved. Second is rural. 3 is sort of, have insurance, no issues. And we're actually going to our primary care folks and saying, okay, what exactly do you need? For one group, it might be, I want a dashboards, and MA in the clinic will run it and then discuss with the PCP. The second one is to your model. So we're working with, Dr. Zohar, who's in the audience, of sort of, we have a hepatologist who goes there and once a month we'll review, the cases and have this mini consultation. And for the third, sort of the private insurance, it's this e-consult mechanism. So I think, this kind of approach is going to vary, and we'll just have to try it out, and VA might be a different way to do it.
Yes, Dr. Kadri.
Good morning. I'm Sayar Kadri. I'm a hepatologist here at Baylor. And we've had an ECHO program for going on almost 10 years. And so I don't know if this sounds dramatic, but it really made me sad that I think one important thing that Dr. Fortune also pointed out is that we've had this ECHO program, and we've seen the number of patients being presented has dropped off. And we thought maybe primary care just isn't interested in anymore. And I know the need is there. And so I think we missed that feedback, because I'm sitting here, I have an ECHO program, 1.5 hours every week, right? And it's not working for some people, clearly. And so we missed that feedback. And I think it's important to get that from the people on the ground, right? So that's one point. The second thing is, like you said, we need a champion in those clinics, and the clinic has to support that champion. So not everybody's interested, not everybody has time, and I totally understand that. But usually a clinic can find one person that is interested, and then that office has to support them. In some states, primary care physicians, providers, they get paid to present their patients in ECHO, and that's a great incentive. So I wish we could do that for our providers as well. The other thing, I have this great advantage where my college supports me for doing ECHO. So nobody questions why I'm not seeing a fatty liver patient while I'm doing ECHO. So I think that's important too. As a specialist, I have great support. So in Texas, I'm here. ECHO at Baylor is here to help whomever. And the other thing is, I don't just do Hep C. So we do Hep B. And I did a PBC patient the other day. So when my providers come and say this patient has cirrhosis, or I don't know, the liver enzymes are elevated, we work with them and we help them figure out, like a PBC diagnosis just recently. So I wish I could reach out to those people, or you could put them in contact with us, because we've got a thriving ECHO program going on 10 years, almost 3,000 patients that we've seen. 60% uninsured. And I honestly tell my people, the people that are participating, I've learned so much more from them than they've learned from me. Because, like you said, it's reality. And I work at a place where people have insurance and they have some money, but that's not where the sickest patients are and the most needy patients.
Well, thanks for saying that. What I did mention, one thing is that once you get people, the PCPs and their team, past trying this out, it's so exciting to cure something, because we have so many diseases like diabetes, like obesity, that we have a hell of a time managing. And this is very rewarding for people. And so once you can get them past that stage, usually it is one person in the clinic. I have to say that other clinic providers kind of go, yuck. And until we have something that makes them really care about it, I think it's a problem. But if you can find those people who are willing to try it out and see the wonderful success, but they need that team. There's no way you can put it on a dock in a box without the team. I just feel like you're doomed if you don't have that.
I thought your presentation nailed it. I mean, it's a competition for resources.
Yeah.
Everyone thinks their disease is the most important, and they're probably all right. And what makes your reminder better than mine, if you're paid for it or if it's a quality metric? And we are so fortunate to have the CMO of United Healthcare community plan here with us today, Dr. Deshpande. So he's the payer's perspective. And between the payers and the policymakers, if we do it right, the providers will be incentivized to do this. In a disease where the information is ripe, there's nothing to guess about hepatitis C anymore. There's a lot to guess about NAFLD, I'll give you that. I mean, if a payer says, hey, this is way too far, give me demonstration, I would understand. But Hep C and Hep B, just do it kind of thing. And the do it part cannot rest on volunteerism. I mean, it's beautiful, but you can't cure hepatitis C based on someone who's well-intentioned. I have a question. Yes, Dr. Ward.
Okay, thanks.
And then one last one,
Okay,
and then
quickly.
coffee.
Okay, great presentations. John Ward, I'm with the Task Force for Global Health. I was formerly at US CDC, where I was the Director of the Division of Viral Hepatitis, and had the pleasure of working with a number of people in the room. And so these are great presentations. I had a question for, Barbara. It seemed like a lot of what you were raising were the complexity of the system more than the complexity of the disease. I mean, around the world, there's been this huge move towards simplification of HCV treatment because of the safety of the drugs and their high impact. And, and this adage, 60% adherence, 90% cure, even for hepatitis C. And so it's really, makes a big case for simplification. So is my assessment correct on that, or did you actually, in your own trajectory, see that simplification is happening for HCV care? And then I had a question for Sumit in that, this issue about a reminder fatigue is legitimate, but it's because physicians, they're going to rank what they think is important, and they don't think liver disease is that important, so they'll just disregard that particular reminder. So is there any change in medical education that's increasing the emphasis on liver disease and the importance of early diagnosis of liver disease, so that when those clinicians actually go into practice, they don't disregard that health alert anymore? But thank you, Barbara. Thank you, Sumit.
Yeah, I have a quick answer. Over the years of our project, it got way simpler with pan-genotypic drugs. So that was a huge advance that made it all so much more straightforward, and short course therapy. So I think the complexity is implementation, not the disease, And I want to make it clear that it's got a lot of components that have been pointed out by all of us. And if you ignore that complexity, you're not going to get to managing a disease, which is actually really quite straightforward. I agree. It's kind of like sailing, though. Sailing is like, all the time. And then a wind comes up and you have tough patients who are complicated, and that goes way above my pay grade. And people get very scared, the PCPs do, if they run into that. So you've got to have a good relationship and a place to send people when things get very complex. That was a bit of a problem in our practices because they were uninsured. Thanks.
Several components. One is, at this point, education is still one-on-one. I think we have to target every single practice in a different way and say, what are your needs, and let me give you that information the way you need it. That's one. Two, from the patient perspective, we're actually empowering our patients more. So in our clinic, it's videos that we've created on these topics that are on autoplay. While they're getting a tap or getting fluid taken out, it's an autoplay. So then they sort of spread the message also, hey, what is this liver disease that you're sort of talking about? And at the system level, we're making the economic argument. We're saying that in about 3 years, you're going to have, huge number of fatty liver medications. How are we going to adjudicate who needs it, who doesn't need it at the system level? Help us identify these patients early. So that's sort of the system buy-in. And then in terms of that epic fatigue, I was thinking about it, it's our kids used to mow yards. If I could just pay them $20 and look and clean up my Epic inbox, I'd be happy, but I'm not allowed.
One last comment here before coffee?
So yeah, I'd like to make a few comments. I'm Jeff Zohar, and the perspective I bring to this is as a practicing internal medicine pediatrics physician. I appreciate the specialty in the room and the perspective that you bring. At the front line, I want to echo everything Dr. Turner is saying. I think this is so critical. My experience has been treating HIV/AIDS in Africa with Baylor College of Medicine 10, 15 years ago. We had frontline caregivers giving specialty care in high-risk, high-need situations. And then bringing that to the United States with federally qualified health centers, you have primary care doctors that are giving this care that we'd love to have the specialty access that we are describing here, but that doesn't always functionally make it there. I think where we are now is you've so eloquently illustrated this idea of a care team model where you have care managers. We've been very fortunate to have integrated care teams that include behavioral health, because we talk about substance abuse, depression, why are we drinking? Alcohol, these are all drivers that behavioral health is a huge factor. Pharmacy, chronic disease educators, this is a team-based care. So as we're evolving in our healthcare model, we can provide the best care at the level of the clinic where our patients are coming in. And these components of care that we're describing need to be at the level of the patient, at the community level. And we can do it. This needs to translate into health economics. It needs to translate into how is this so much more affordable for our states, for our government, for our hospital systems, that why aren't we, to Samit's point, taking this all the way back to let's treat obesity, not end-stage liver disease and hepatocellular carcinoma. Let's treat our sickest communities and give them resources to do that. That is policy, and I'm glad that we're talking about it, and I think we have the right people here to do that. So I value everything you've said, and I want to echo that I think that we're on the right track.
Thank you very much. Thank you, everyone. Coffee is in the back. We'll resume exactly 10:20 and probably a few minutes before that so we can stay on time. Thanks again.
Thanks.